The Factors Influencing Pediatric Asthma study was conducted on the Cheyenne River Sioux Tribe in Eagle Butte, South Dakota, with about 100 children who had asthma and about 200 children who did not have asthma that were matched by age.
Our study was trying to find out if the factors that increase the risk of asthma are different for American Indian children than in other populations. And we found 3 factors that seem to have the same effect. One of the factors that we found increasing risk of asthma in our study is obesity. This has been found in other populations as well. An increase of about 15 pounds for a child 4 feet tall increases the risk of asthma by about 10%. This may not sound like a very large increase, but it's another of many reasons to keep your child's weight under control.
Of the controls who were studied, so this is the children that did not have asthma, we had a 55% rate of being overweight or obese. Even more surprisingly, 71% of the asthmatics that were in the study fell into that same category of being overweight or obese. There's definitely more need for researching this area between the relation between obesity and the impact of if we're able to reduce our obesity levels in these asthmatics, if it does have an impact on their disease severity or control.
The other 2 factors we found were the allergic tendencies of some people seems to increase their risk of asthma as well. Doctors call this atopy, and many people refer to it as allergies. Our immune systems are critical to fight infections, but sometimes it gets carried away. Like a dog that barks at every sound, it tries to fight against things that are common and not really that harmful. Some of the things might be dander from dogs or cats, common molds or pollen from weeds. When our immune system overreacts like this, doctors call it atopy, but most people just complain about allergies. Our skin may develop eczema, our eyes may itch, our nose may run, and we are more likely to develop asthma. The third and last factor we found was the same, where certain small genetic changes that have been found to increase the risk of asthma in other populations seem to have the same effect in our study.
The reason we study genetics in relation to asthma is so that we can better understand the biology related to it. This helps us identify new treatments that can potentially treat asthma, as well as preventative measures that can be taken to control asthma. Genetics are not determinative or defining for asthma, but they are important to study.
The average person has about a 10% chance of developing asthma as a child. If they have a close relative, like their parents or brother and sister, that risk is doubled. So we know that the genes that you inherit from your parents increase risk. Nothing is sure about this, though. Some people have parents who have asthma, but they don't have it themselves. Others have asthma themselves, but have no other close relatives with asthma. Other scientists have found that certain tiny changes in the spelling of the DNA that we inherit can increase the risk for asthma. These changes seem to work in combination with our environment, perhaps exposure to dust or tobacco smoke, to bring on asthma in certain people. We tested 10 of these DNA changes or variants in our study and found that 6 of them had the same effect as in other populations, and 4 didn't seem to have any effect. We also found that one of these changes increased risk only in children with allergic tendencies, whereas the other 5 increased risk only in those without. If a child inherited one of these genetic variants, the risk of asthma was approximately doubled, but still nowhere near 100%.
So from that finding, we are not so different than other races, because that is a finding of all races in general, that asthma is atopic. Another significant finding from the FIPPA study is that the education that was associated with the intervention group of the asthmatics did not have an impact on emergency room usage. That consisted of bringing information on an asthma action plan, medication usage, asthma triggers and avoiding those triggers, and the correct way to use those medications and when to use those medications. What we found, though, is that it didn't have a significant reduction in emergency room visits, and we basically want to know more about what will work to make the children who do have asthma be able to have a better quality of life and better control of their asthma symptoms. So basically we'd like to modify that intervention piece and retest it and see if there's any anything new that we learn as far as what works in helping these kiddos manage their asthma. In closing, what we've learned from this study is that we're more alike than we are different. That American Indians and what we know about asthma in all races have a lot of similarities from what we're finding so far. However, the data analysis is not complete yet for this study, and we expect more significant findings to come, so definitely stay tuned. We also want to identify that there needs to be more research done, especially in regards to an effective intervention program for American Indian children with asthma, as well as the relationship between obesity and asthma in Indian country.